Hi, I'm Colin Brathwaite. I'm a general surgeon, first and foremost. But within that specialty, I do a number of different aspects of surgery. One of my practices is robotic surgery. Another is bariatric surgery, which is weight loss surgery. We call it metabolic surgery now because the surgery involves treating a number of metabolic diseases, correcting diabetes, for instance, and having an impact on various aspects of heart disease, and that's called metabolic and bariatric surgery. I also do things that are considered as foregut surgery in the upper aspect of the GI tract, involving hiatal hernias, surgery of the stomach, and other hernias. And my practice is primarily limited to the abdomen, so I do a lot of abdominal surgery and just about anything in the abdomen. Why did I get into medicine? I actually wanted to become a physician since I was 7 years old after reading about a missionary doctor that went off to Africa, Dr. Livingstone. And I think the key thing is ever since I said I wanted to be a doctor, my mom never let me change my mind after that, because anything else I wanted to do, she just brought it right back to, I thought you wanted to be a doctor. So, but when I did get to medical school, I encountered the head of the Department of Surgery there, Dr. LaFall, who is regarded as a giant in American surgery. And I really, in the anatomy class that he came and lectured on, I just felt that he did everything that I wanted to do. And at that point, I wanted to be a surgeon and never really looked back. So I've been at Winthrop, now NYU Winthrop, for just over 10 years. In my capacity as chairman, I have been in this role for just about 5 years. And additional responsibilities I have include being the director or co-director of the Fellowship of Minimally Invasive and Advanced GI Surgery. In that capacity, I help to train surgeons on robotic surgery and minimally invasive surgery. It involves also training surgeons on techniques in bariatric surgery. And I do this at the local level at our hospital, as well as participating in societal meetings and courses around the country. I've had a strong interest in research over the years, and this has involved various aspects of my practice. Several years ago, I practiced in trauma surgery and did a lot of research in that area. Currently, we're doing a lot of research in obesity, the impact of bariatric surgery on various aspects of metabolic conditions. So we're looking, for instance, in rat models of how gastric bypass or sleeve gastrectomy can actually correct diabetes. We're finding that it has an impact on the elasticity of the vasculature, so vessels like the aorta, that we can correct some of the aging defects that happen with hardening of the arteries. That can be corrected with weight loss surgery because we're having an impact on the metabolism. And that's something we're still trying to understand because it is one of those areas that is still somewhat nebulous. We understand that it works, but we're trying to have a mechanistic approach and understand why it works. When I started out in surgery, after my surgical training, I did a fellowship in trauma and critical care, and that gave me an exposure to the most critically ill patients. And I trained at the leading trauma center in the country at the time, so I dealt with the sickest of the sick, and I've translated that into my bariatric surgery practice. At the time that I started doing bariatrics, most people were very afraid of operating on those patients because they were critically ill, they were just a lot of problems. But I've taken pride in the fact that I commit myself to those patients who've had bariatric surgery and having issues that need revisions, and also patients who have complex other surgical conditions. And when a patient comes to me, I look at them and see, is this something that I can help this patient by surgery? Is this a situation where I can intervene and provide some help? And I look at the situation and get all the tests, and if I feel I can help the patient, I'll take the case on, as complex as it may be. And I can tell you that I've had a number of patients who have gone into New York City at some of the major centers, and One patient said she was actually told by a surgeon that you're going to mess up my numbers. You are just too high risk. And we were able to offer her a minimally invasive approach to her problem, and really she's gone on to do very well. So that, for me, is what's most important. Can I do something that will help this patient, regardless of what aspects of surgery that we're dealing with? So I feel like I'm here to help.